Welcome to this ASCO Journal of Oncology Practice podcast. This is Dr. Bob Miller of Johns Hopkins and consultant editor for JOP. This is the fourth in our series of recently revamped podcasts for the Journal of Oncology Practice, where we've been featuring interviews with the authors of articles in the current JOP issue so they can provide some additional details and information about their topics. The November 2010 issue of the journal focused on the important topic of multidisciplinary cancer care. I'm pleased to have as my guests for this podcast two of the contributors for that issue. Dr. Joseph Jacobson is a practicing medical oncologist and chairman of medicine at North Shore Medical Center in Salem, Massachusetts. He was past chair of the ASCO Quality of Care Committee and is an associate editor for JOP. He conceived and developed the topic for this JOP issue. Welcome, Joe.
Thank you, Bob.
And our other guest from a little further north in New England is Dr. Denis Hammond, who wrote about the challenges and rewards of implementing a multidisciplinary breast clinic in his own practice in a community hospital setting. Dr. Hammond trained in hematology oncology at the MGH and the White River Junction VA, and he has been practicing in southern New Hampshire since 1978. And welcome to you, Denis.
Thanks, Bob.
So let me start with you, Joe. Talk a little bit about the background for this special issue of JOP on multidisciplinary care. Why was the journal interested in publishing this, and how did you go about getting manuscripts?
The topic was first brought up about a year ago. The editors meet on a regular basis by teleconference. We reviewed some of the specialty issues over the last 5 years and recognized that there was a gap around integration of cancer care and thought that it would be challenging to try to put together an issue that was totally focused on multidisciplinary care. So a goal to really identify a topic that was patient-centered and had real appeal across a spectrum of providers. We knew of several practitioners in the area who were passionate about multidisciplinary care. Denis was one of them, and we reached out to him directly. We reached out to several other practitioners and then decided to do something relatively uncommon for us at the Journal of Oncology Practice, and that is to post a call for papers that sat on the ASCO main page website for a couple of weeks. We were astonished by the results. There was an unprecedented response with a total of 43 manuscripts received.
For the first time, the JOP published some of those manuscripts only on an online setting and not in the paper issue.
Yes, that's correct. We have a limited number of pages that can be published each year in the JOP, and we had an extraordinary array of high-quality papers. So in addition to the 5 that appear in print, another 9 are published electronically and are available through the JOP website.
So, Joe, you in your article, your sort of editorial, you talk about a case presentation, a patient named Jane Forbes, who I assume is a pseudonym. Tell us a little bit about the story and why is that really emblematic of the difficulties with care coordination in practice today?
And Jane Forbes is a pseudonym and based on a real patient, and one that I learned about during the process of helping to put together the issue. And, her case, although extreme, defines the kind of challenge that many patients face across the country with a new diagnosis of cancer. And that is that newly diagnosed patients with cancer are suddenly confronted with high levels of uncertainty, many having enjoyed good health or not thought much about their health up until the time of the diagnosis of cancer. Mrs. Forbes' case is an example where the anxiety associated with the uncertainty was magnified many times over by all the uncertainty that was added by a healthcare system that was quickly proven to be not up to the task of managing her care effectively and efficiently. So I think she describes, again, an extreme example of a common outcome for someone diagnosed in the United States with cancer.
I read the case, and I can certainly think of numerous examples of patients that I take care of that the sort of the delays and the extended periods of time that transpired in between visits to specialists. I mean, I think if we reflect for a second on what it's like at the patient's end to think about these delays, I think it's sobering.
There were two parts I would say that were missing in her care. The first was the lack of coordination. Who was really in charge of her care, I think, was never clear. But more fundamentally, and I think the overriding issue that I tried to focus on in my editorial is that there was no system of care to look after her.
Let me ask Dennis. In your article, you deal with basically the same topic, and you talked about some of your frustrations in trying to set up a multidisciplinary clinic in the community setting. So, tell me a little bit about that, and particularly how did the economics of the whole thing impact the difficulties you faced?
I had two general experiences. One was, I would say, a failure and has remained a failure, and the other is more successful, and that was the more recent experience. So in the first instance, there were two hospitals in a community that were competing, and there were multiple physicians who were, in this case, providing breast cancer surgery. There was only one radiation therapy group and one medical oncology group, which simplified matters. But none of the surgeons were willing to relinquish any control or cede any ground in the area of acknowledging that they weren't the most expert person to do breast surgery. And it quickly became clear that everybody had sort of dug in their heels. Neither of the hospitals took any leadership in that. Everybody appreciated that this type of multidisciplinary care had the potential to be very inefficient, especially in a system where we're paid a certain amount for a consult, and that's it. So the whole thing kind of fell apart in spite of good intentions. The second experience was a lot more satisfying in that there was one hospital with basically one group of surgeons who were very interested in breast surgery, and the hospital was very interested in promoting this and put the economic engine in place to pay practitioners to participate in this clinic, paid per time, not based on the number of patients seen. That clinic eventually has succeeded in some ways.
So this model where the hospitals are actually paying the physicians directly, how did that integrate with any professional fees? Was that separate from the pro fees?
So in that institution, all the physicians involved were employed or on some kind of professional services agreement with the hospital. So that either there was an RBRVS type of payment or a per hour payment for medical directorship and administrative services. And that made the thing make sense. Whereas if the time spent in conferencing and coordinating care all was washed under the rug, and the only thing that one could get paid for was the face-to-face time with the patient, it became very unappealing economically.
In your article, Dennis, you also talk about the importance of champions for the process. And obviously, for something like this where there's a lot of barriers, I guess it goes without saying, you need someone who's passionate about it. Who was the champion? Was that you? Was it someone else there? Is it always a physician in your understanding?
I don't think it needs to be a physician, but it was in the case of the hospital in which this multidisciplinary clinic ended up being successful. And this was a female breast surgeon who had practiced in Philadelphia and also in a setting similar to the setting in which she had now found herself in New England. And she was not only passionate about breast cancer surgery and the care of the woman with breast diseases, but also passionate about this multidisciplinary model. Quite frankly, given my initial experience and my skepticism about this, I had to be sold on this. But it really has turned out to be a wonderful experience intellectually and in terms of patient satisfaction. That being said, it is not a very efficient way to carry out care, and that sometimes is frustrating.
It seems like it varies across disease type, and so for a breast clinic, it's probably true that the medical oncologist is the least important part of the team, or maybe I should say that they certainly don't need to see every case. So and this is a question for either one of you. In breast clinics you either were involved with or are familiar with through your work for this journal, what did you do with the medical oncologist, I guess? I mean, in our own institution, medical oncologists see the neoadjuvant patients, but that's about it because you don't have the final path. So how was that handled?
I can speak to a multidisciplinary GU clinic that I participated in, not breast cancer, but GU, I think, for many years. So I was a medical oncologist leading patients with early stage prostate cancer. I had nothing to offer them therapeutically, but I found that it was actually a fertile area to educate patients, to sometimes help them think through the contrasting opinions that they were getting from radiation therapists and surgeons, both of whom always had very strong opinions, often in favor of their particular therapy. So I felt in the role of the medical oncologist, I was able to help be a fair broker and an interpreter of a complex literature, and that in itself seemed to serve a valuable function for the patient.
So you were sort of a tiebreaker vote at times?
For sure.
I would echo what Joe had to say, which is that I think it was comforting, or it frequently is comforting, for patients to hear someone who's expert but doesn't have a dog in the fight to either mediate between some somewhat contrasting approaches to treatment by either the radiation therapist or the surgeon or both, or to validate what they've had to say, knowing that, we as medical oncologists don't practice in that area. So I think that our participation is worthwhile, even in the cases in which we don't have a direct therapeutic role. The other thing is that in a multidisciplinary clinic, one of the advantages is that hopefully patients hear a relatively coherent approach to their problem, or at least understand why there may be variations in approaches. And so it's good to be part of that conversation. Sometimes I think we have the experience when we see people not in that setting where someone will say, well, you've just talked about this problem being handled in this way, but when I saw Dr. Jones, she said that it should be handled in another way. And how do you square that? And, then you end up backing and filling, where that doesn't happen so readily when you're all sitting around the same table or have heard the same conference information.
What is the in the breast clinic again? In the patient's experience does the medical oncologist see every patient? Was that the way you practiced there, or was it just selected cases?
We see every patient. Sometimes we feel we don't have much to say. So in all, I must say that I don't think I've come out of any interview with a patient without feeling that something's been contributed by my presence, even if it's just to say that you don't need to see me right now. Just to have heard that, I think, is frequently helpful.
Let me ask Joe along the lines of best practices. Do we have much data about what's the best way to see patients in this setting? I guess I'm thinking more of the process and operational things. Are patients seen simultaneously with all the specialists? Is it concurrent? And do you know, is there any literature to support any of this?
I guess I think of multidisciplinary care as following a spectrum that begins on one end with a tumor board, in which cases are often discussed after therapy has already been initiated, the classic tumor board where interesting or complex cases are discussed over a lunch with caregivers from different subspecialties. That would be one end of the spectrum. And then on the farthest end is a true multidisciplinary clinic that is set up in a synchronous fashion so that a patient arrives at a scheduled time with the expectation that they'll meet multiple providers from different specialties, and that care will be coordinated during that visit. And at the conclusion, hopefully, a care plan will have been defined. There is a lovely patient article in this issue of the JOP by Gansos O'Brien, a patient who was discovered to have a pancreatic mass and was referred into a high-functioning multidisciplinary clinic. And she can describe far better than I the advantages of that sort of approach. I don't know that the multidisciplinary clinic, the synchronous clinic, is necessary for all patients. Certainly, if the initial part of their therapy is straightforward and the requirement for care is going to be with a single modality, it may not be necessary to have that sort of platinum level care. But meeting multiple practitioners, either synchronously or in series, I think is hugely reassuring to the patient. In terms of the literature, it's pretty scant, and I did not come upon a paper that would meet the true test of proof of principle. That is, there aren't randomized clinical trials looking at the value of multidisciplinary care. There are a series of retrospective studies. There are some population studies that have been published, and they identify things that I think have a lot of face validity, that the time from biopsy to initiation of therapy can be reduced significantly. Multidisciplinary clinics, when they're functioning well, often will alter the therapy that may have been defined before the patient got to that setting. And one study by Chang showed that 43% of patients who were seen first in a standard oncologist setting or surgeon setting and then went to the multidisciplinary clinic had their approach changed in 43% of cases. Patient satisfaction is improved by virtue of reduced number of visits, a greater sense of confidence in the treatment that's been recommended. There's some studies that show better adherence to evidence-based guidelines, and that includes one or two of the papers in our series. The one that comes to mind is the NOD series from Australia. And then finally, some evidence exists that enrollment in clinical trials is enhanced.
It must have been encouraging to get all the manuscripts. I mean, seeing that this was done successfully in different countries and in multiple different settings.
So, and what struck me most was how much innovation is going on throughout the world trying to tackle this problem.
Mm-hmm. Dennis, in your setting, did you or your hospital employ any type of formal measurements of patient satisfaction or outcomes, or any type of modeling in terms of return on investment, even, say?
Well, the latter I can say unequivocally no, or if there is any data on that, I certainly haven't been privy to it. In terms of patient satisfaction, I think that we do have the Press-Ganey data, which most hospitals have, and that has shown a progressive improvement. So that's one measure. I don't know the scientific validity of Press-Ganey data, but it is something that we've looked at. Before we had this conversation, I mentioned to you that I had been to a meeting of the Cancer Center Business Summit in Chicago, and there was a speaker from Oncology Solutions, Rhonda Milor, and she had a very interesting and, echoing what Joe had to say, a very innovative approach to multidisciplinary care. What she suggested is that a hospital or a group of practitioners get together and decide what their goals were. What did they think needed to be improved? And instead of starting with a result, a mechanism, to look to achieving a goal or goals, and then design a system or systems that they postulate, or we would postulate, would achieve those goals. And in that process, to build in mechanisms such as pathways or research protocols, and at the same time to build in measuring systems as to outcomes that we think are important, and to use this kind of TQM model to continuously improve the process and let the multidisciplinary aspect of care kind of grow organically around those goals. And I thought that was a very satisfying kind of model, and it's one that she has utilized in helping communities and practices develop multidisciplinary care, and claims it's been quite successful, and that by and large the clinics or the processes that she's worked with have ended up not being kind of brick and mortar clinics, but more virtual clinics, which I thought was very interesting. But I think that that's something that we didn't do. We started with the postulate that we wanted a multidisciplinary clinic, and now I think we need to backfill to look at pathways, research protocols, and measurements to try to determine how successful we're being.
It certainly sounds like we have a lot more work to do in understanding, what the patient's needs are, but doing it systematically and certainly involving a pathway process sounds like that's an important first step. So I hope we do hear more from that particular researcher, and I'd like to read more about her work. So maybe you can share a link with us. We can put that on the website if you can get that information to us offline.
I'll try to do that.
Gentlemen, I want to thank you for taking the time to talk to me tonight about this topic.
Pleasure. My pleasure.
And I hope our listeners take a look at the entire issue of the November JOP for the additional great articles about multidisciplinary care. As we mentioned, there's a series of articles that are in the web exclusive portion. You can find those online at jop.ascopubs.org. Please let us know what you think about these new JOP podcasts, which are now available on iTunes, by the way. You can send comments and suggestions to jopeditorsdesk@asco.org. This is Dr. Bob Miller for the American Society of Clinical Oncology. Thanks so much for your attention.